What do you think is the most important assessment oncology nurses should do to evaluate their patients for SREs?
I think the main thing that people need to remember when they're assessing a patient is to have, there's not like a particular tool or way to do it, but it's to have that index of suspicion. You have a patient who's metastatic, for example, breast cancer, prostate cancer. Generally, a prostate cancer will present that way, but here's a young metastatic breast cancer patient comes to your office and her shoulder hurts. Having that index of suspicion that will investigate that will look into that and will check a little further, that's the most important thing. There's not one test that's more important than another, other than listening to your patients and seeing what they tell you.
Can you discuss some of the patient and family issues that SREs can impact, and what's the oncology nurse's role in patient safety?
Well, right now, there's a lot of work being done with patient navigators and that whole role. Well, is a navigator a job description or a role component?
Good
and
question.
I think that it is a very important role component. So if you put in that navigator part of you, and you've got a patient who presents with SRE, you're not just looking at how to get that person to his radiation therapy or to get the person in the chair for the Zometa. How are you going to help that patient and their family navigate all of these things? Because it isn't just the patient, it's the wife, the daughter, the son that had to take off time. You're going to have to drive every day to radiation therapy. You're going to get back and forth to the orthopedic surgeon. It is a family affair that is going to affect them. And I don't think, we haven't done the studies yet, but we don't really look at the cost of the caregiver. And one of the things that as a nurse, as an oncology nurse, and we do that very well. I mean, we've all been around a very long time. And that's why, because if you look at that, if you look at what the family's experiencing, then you can help them navigate. And I think that's a very important thing as we go forward talking about nurse navigation. It's what we do.
What's the difference between blastic and lytic metastases?
Well, on a day-to-day basis, you and I sitting in this chair and all the people, we're in Congress right now walking around, we're coupling and uncoupling our bones and balancing out the effect. That's very normal. But with certain malignancies, that coupling breaks down. And for example, in prostate cancer, the breaking down part is suppressed, but the building up isn't. And you have swelling, sclerotic lesions, and that's blastic. Thick and lots of it, but very weak bone. That's blastic, that's hot. You see it on a bone scan. Those tend to be excruciatingly painful because of the covering of the periosteum. Then you have lytic lesions, which are the opposite, where you're breaking down the bone, but you're not building the cement back. And so it digs and it digs, painless until it breaks. And that's the stuff on plain x-ray, looks like moth holes. And when you have a multiple myeloma patient, don't bother with that bone scan, but you're going to, and you know, in some breast cancers too, it's going to be a mixed bag, but those are the lesions that are silent until they cause a problem.
Until they break, exactly.
Yeah.
What's one of the most recent challenging patients you've had?
A young breast cancer patient with a mix of blastic as well as lytic lesions. And because the fact of the matter, she's young, triple negative, not really effective therapy that we can do for her. A family of young children, BRCA positive, of course there's daughters. And how do we put our hands around that patient and around her family to support them through it? We know where it's going to end, but that doesn't mean we don't do things that are going to help support them. And a lot of that comes into the realm of supportive care with their skeleton. How can we strengthen it? Because yes, we know where this is going to end, but that's not going to be today or tomorrow. She wants to be with her family. She wants to be an active part of her family. And then working with her to, the bisphosphonate Zometa was easy. There's no problem with that. And it was very, but how do we manage pain control in a young woman who is in pain but wants to be with her children? How do you,
and doesn't want to be sedated.
And
the patient safety issue is so important.
Yeah, and you know, you don't want her to fall, and you don't want the children to, I mean, it sounds silly, but you don't want her children getting into the, so all of these issues, and then the grieving husband that, you know, if if my wife is taking narcotics, isn't this really bad? No, it's okay.
Yeah.
You know, and all of those things that go into it. And like it takes a village to raise a child, it takes a village of nurses to help this person through
And
the
the
journey.
family. One of the questions I'm asking all the key opinion leaders is essentially, how has the nursing shortage impacted your practice environment?
Well, the good news is, been there, done that, and we'll do it several more times, and this too shall pass. We are in the flux of not knowing, and so unfortunately, and I have to tell you, my mother was a nurse for 50 years, and this is what she told me. If in fear or in doubt, run in circles, scream and shout. That's what healthcare does, and we're doing that, but we will get through it. As I've said before, how we do it will be how bad the nursing shortage will be on the other side. But what we have seen, what I have seen in my experience, clinical as well as administrative hat, is how do I preserve those nurses around the patient? That's the most important thing. I think we're going to see some nurses that we have grown and developed over time. This is not the time for them. I would rather have staff nurses either in the infusion or inpatient or office.
And the hands-on patient care.
Hands-on people, and we're going to struggle. What I hope is that advanced practice nurses will come out of this stronger as a better defined group, because again, across the country, maybe advanced practice is not as well
Kind of means
defined.
different things in different areas, yeah.
But advanced practice nurses are so useful, and we will be very key in getting through this, because frankly, when more patients can afford care, they're going to need more of us doing those sort of things. Not enough people to go around. So I think that the challenge I have, and I know everybody who's going to be watching this and everybody's here, not only how do we support those people, how do we educate them? You can't go off to an all-day seminar. It's unusual to see all these people here. The challenge is going to be, how can we get this information to them in innovative ways, like what you're doing right now, the webinars, et cetera, et cetera. So make a very long story short, out of every crisis there's opportunity. This is just the last one, the latest one in my career and other people. But again, we don't do this one right, then at the other side of it, it's not going to be
And
like
it'll
the
be
others.
back. It'll,
Yeah,
it's
it will
very,
be
very
back.
cyclic.
Yep.
What can we do to, the primarily women walking around with new member, first-time
Yeah.
Congress attendee,
Yep.
to make sure they're here in oncology next year and make sure that they're part of the workforce?
Frankly, what you're doing, what Imer is doing, not to plug things, but I thought it was the coolest thing I ever saw, the jump drive,
Oh, yeah.
the CD, making those things available, finding many ways, because it may not be possible that gazillion people come here anymore.
Right, that's true.
You know, but we need to get that information to them in a way that's convenient for them. Making it, keeping it real and making it relevant is going to be exploring these new technologies and new ways to educate people, because people aren't likely to continue to pay for it the way they used to.
Well, we've seen that
Yeah.
change.
Yeah, hospitals
Absolutely.
cut stuff, practices can't afford it. So how can we get there
Get the education.
and
to
get, because people invariably identify their worry about how do they find out about new stuff. If you do any kind of needs assessment, the first thing they want to know about is new stuff, new tech, because they want to be able to give it and do
That's
it right.
Exactly.
So they say that, and it's deeper than that, but nurses want to make a difference. We are not little tech people that, plug things
No,
in
we
and
wanna
walk
make a
away. We
difference,
want to make a difference. We want to know how, and we want to feel important about it too.